let's move on to our next topic, which is inflammatory bowel disease. So in this case, you have inflammation. It's very obvious. In IBD, there are two forms. One is ulcerative colitis and the other is Crohn's disease. Let's talk about ulcerative colitis. Ulcerative meaning there are ulcers being formed secondary to inflammation. Colitis, here the colon is involved, that is large intestine is involved. Ulcerative colitis does not occur in small intestine. Why is there inflammation? The inflammation is secondary to autoimmunity. So you have P ANCA which is produced and that leads to ulceration. If the rectum alone is involved, it is called proctitis. Proctitis is a subsegment of ulcerative colitis. If the rectum and sigmoid is involved, it could be rectosigmoiditis. So how does the patient present? What are the clinical manifestations? They have diarrhea, they have blood and mucus produced in addition to diarrhea. As you can see in IBS, we only had diarrhea. So your blood and mucus is produced in addition to that because of the inflammation. They also have extraintestinal manifestations. These are because of the immune reactions. The autoimmunity is not just in the gut, but also in the skin and subcutaneous tissue. So it can cause erythema nodosum, it can cause pyoderma gangrenosum, it can cause polyarthralgia, cause aphthous ulcers, etc. Do a blood test. There's raise in inflammatory markers such as raise in CRP, there's raise in WBC count, and there's reduced albumin. So why there is a reduced albumin? Liver is where the inflammatory markers like CRP are produced, and liver shifts its focus from producing albumin, which is a synthetic function of liver, to producing CRP. So there is downregulation of albumin production, upregulation of CRP production. Ulcerative colitis is a long-term chronic illness. There is no cure to it. There is just managing the symptoms. So how do you know if the patient needs to be admitted or can be treated as an outpatient? This is based on Truelove and Witt's criteria. And ulcerative colitis is classified into mild, moderate and severe according to that. How do we diagnose ulcerative colitis? There is clinical presentation, then there is a blood test which we discussed about, and then there is definitive investigation such as an invasive one, which is a colonoscopy. Here I'm telling about colonoscopy or sigmoidoscopy. It's not an endoscopy because we're not involving the small intestine. Initially, when you suspect ulcerative colitis, you start with a sigmoidoscopy. In sigmoidoscopy, you could see inflammation, erythema, and also pseudopolyp. In ulcerative colitis, it is not a transmural inflammation. The inflammation is within the submucosa. So the ulcers are not deep, but there's widespread ulcerations and very little tissue, which is normal mucosa, is left in between the big ulcers, which looks like a pseudopolyp. During sigmoidoscopy, they would take a biopsy of it and look under the microscope and they would see the neutrophil aggregation. That's a definitive diagnosis. Abdominal X-ray can be done to rule out bowel perforation, also to check for a toxic megacolon and mucosal thickening. At the same time, CT scan with contrast can be done to look for mucosal thickening. How do we treat ulcerative colitis? Because it's an inflammatory pathology, you would treat by giving steroids to start with. So corticosteroids are given, and if it's a severe case coming to the hospital, you would give them IV hydrocortisone for a couple of days and see how they respond. First line of treatment would be 5-aminosalicylic acid. In case of proctitis, topical 5-aminosalicylic acid is given, or enemas are given with 5-aminosalicylic acid. In case of ulcerative colitis in general, oral 5-aminosalicylic acid is given. Other steroid-sparing agents can be given, such as azathioprine, methotrexate. And if it is refractory to steroids and steroid-sparing agents, then we would go for cyclosporine and infliximab, which is TNF-alpha antagonist. The patient does not even respond to steroids for a long time, and this is a recurrent illness, and it's a severe ulcerative colitis, then we should start thinking about surgical procedures like colostomy creation or proctectomy and ilioanal pouch creation.